Dear friends, today is 20th November of 2015. I did this case today. This is a 8 years old girl sustained trauma and developed this cataract. I have planned to do the surgery. Main incision has been given at around 11 o'clock. An air bubble has been injected into the antechamber. One side port has been made at 8 o'clock. The trypan blue dye has been injected to stain the anterior lens capsule, and it is washed out, and a small air bubble is there in the antechamber. Now viscoelastic substance 2% hydroxypropyl methyl cellulose is injected into the antechamber. In this case I can see that the anterior capsule is taut, as we see in intumescent cataracts. One more side port is being made at 1 o'clock. Now I have planned to do a small rhexis, a mini rhexis first in this case, aspirate the lens matter and then make the anterior rhexis bigger. At this time the anterior capsule is being incised. A small flap has been raised near the center of the anterior lens capsule. Now a small rhexis is being made. Now in this case the character of the capsule is such that if you plan to make a smaller rhexis, it becomes a little bigger. So when it became like this, I thought that I can aspirate the lens matter through this opening. I took a direct Simcoe cannula and no hydro was done. Once it so happened that previously when I was doing a case, when I tried to do hydro, there was so much pressure that everything, all the cortical matter, there was no nucleus, all the cortical matter wanted to come out into the antechamber, and it created so much pressure that the rhexis gave way. So I don't do hydrodissection in such cases. In this case I am just aspirating the lens matter. There is no nucleus. I am just aspirating the lens matter with a direct Simcoe cannula. One can do this with bimanual irrigation aspiration probes. Now we can see there is something is sticking to the posterior capsule. These are not cells. These are some fibrous tissue has formed because of trauma. Some fibroblasts have created some fibrous tissue and sticking to the anterior lens capsule. I have given an air bubble, big air bubble. I want to give some more trypan blue injected into the capsular bag. I have planned to do posterior capsulotomy, and I wanted to stain the posterior capsule also. Yes, it has stained nicely, and I hope you can see that. Now viscoelastic substance is again injected into the capsular bag, into the antechamber, and in the capsular bag the bag has been inflated a bit. Now I want to enlarge the size of the anterior rhexis. A cut has been given at around 8 o'clock of the CCC. Now a uterata forceps is taken and the rhexis is being enlarged. It is being done gently because the tendency of this capsule is to go to the periphery and get lost under the iris. I didn't allow to do this. I have made a nice rhexis. It is oval in size. The axis of this rhexis is from 11 o'clock to 5 o'clock. Now I am going to do a rhexis on the posterior capsule. The flap has been raised. We can see clearly because the posterior capsule is also stained with trypan blue dye. Now I am enlarging I am making a CCC on the posterior capsule of the lens. Yes, it is being done nicely. It is difficult to hold the posterior lens capsule, but we can do it with several attempts. Yes, it is nicely done. There is some fibrous tissue superiorly, so I have planned to do. I have planned to use my cutter to enlarge it at the later stage of the surgery. Now I have planned to implant a lens between the remaining posterior capsule and the anterior capsular rim, that is in a capsular bag with an opening on its posterior capsule. The main incision has been enlarged a bit because I want to go into the bag, into the anterior chamber, and deliver the lens gradually into the bag. This is a hydrophobic acrylic IOL. It is made by Abbott Medical Optics, AMO. It is called Technis One. I have no financial interest, but I like this lens very much. Recently I have done surgery of my elder brother, and I have given this lens in his eyes. Both of his eyes has been done in an interval of 1 week. Now the lens is being placed in the cartridge. Both the haptics are on the dorsal aspect of the optic of the lens. Now the lens is being implanted into the eye. Yes, it is being gradually injected so that the leading haptic goes between the anterior capsular rim and the posterior capsule, and the haptic goes to the equator of the capsular bag. The trailing haptic is dialed and it is placed in the capsular bag. Yes, both the haptics are in horizontal position. It's a nice placement. Now I want to remove the viscoelastic substance from the anterior chamber. This is BSS. It is being injected to flash the viscoelastic out through the main incision. Yes, it is coming out nicely. Most of the viscoelastic substance, say almost 90% of the viscoelastic substance, is flashed out of the eye. Now I am going to do anti-vitrectomy in this case through the opening made in the posterior capsule. I have an Accurus machine from Alcon. It's working nicely, and the setting in this anti-vitrectomy is cut rate is about 1000, and vacuum is 175 to 200. The irrigating cannula is in front of the IOL, and the cutter has gone behind the IOL, and anti-vitrectomy is being done to create a space to remove the scaffold over which cells can go from one side to the other side of the capsular margin, so that the visual axis remains clear all the time. When I was in Shankara Netralaya long back, about 20 years back, I saw doing this. Dr. Srinivas K. Rao was doing a case exactly like this. I can say this surgery is an replica of what he did. And I was astonished. I was surprised. It can be done. You can make an opening in the posterior capsule and you can place the lens and you can clear the vitreous in antevitreous so that no cell can go from one side to the other side. See, this is an 8-year-old girl and 100% in cases when the patient is so young, posterior capsule opacification will occur. Now, this is the best way to manage opacification of posterior capsule in such cases. Now, hydration of the side ports are being done. We have come almost to the end point of the surgery. I see under high magnification whether everything is all right or not, whether I have left any particulate matter inside the anterior chamber, whether any cotton fiber is there or not in any of the side ports, and then I come back to the normal position. That's it. This anterior chamber is formed. Thank you very much for watching.